Good afternoon to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Shujit As. Sir is MBBS Diplomat of National Board in Ops and Gynecology, Fellowship in Minimal Access Surgery, Diploma in Gynecology Endoscopy, Senior Consultant in Gynecology and Ops Department at PD Hinduja Hospital, Mumbai. His podcast channel, from Gynac, has been creating a buzz on all social media platforms for all women-centric sensitive topics and health concern. Now, with this, I would like to hand over the session to Sir as he will be discussing on today's topic, breast ovary connection. Over to you, Sir.
Thank you, Shiva. Good afternoon, everyone. We're talking about breast and ovarian connection, mostly talking about BRCA, which I guess everyone has heard about. So let's move on to that part. So we'll be talking about BRCA and how things have changed after this gene has come up when it comes to ovarian cancers and breast cancers. The idea is to understand the genetic and molecular link between breast cancers and ovarian cancers, how BRCA1 and BRCA2 molecular biology has been changing and evolving, and with the information that we get accordingly, how we'll integrate it in screening of breast cancer and ovarian cancers, how we counsel our patients, and how we manage such cases. And quickly in the end part, we'll be discussing about how things are changing when it comes to therapeutics and the preventive strategies. So we can work it out better in overall scenario as well as in lower income states or lower income countries like India. So to get into understanding BRCA, you need to know that in 1866, breast cancer and ovarian cancer clustering was reported for the first time, but it was not until 1990 that Mary Claire King at Washington University localized the BRCA1 gene. Between 1994 and 1995, a lot of evolution around the BRCA gene was done, and BRCA1 and BRCA2 were cloned. Currently, when it comes to understanding BRCA, this breast cancer gene, as we call as BRCA gene, has revolutionized hereditary cancer screening overall. To understand why this topic becomes important, you need to know that as per the WHO 2024 guidelines, breast cancer has been reported to happen in around 2.3 million new cases over a year, which is the most common malignancy for women. When it comes to ovarian cancers, the number might seem less, wherein only 3,14,000 new cases were reported in the year, and it is the eighth most common cancer otherwise. But when you look into the mortality, this is one of the highest mortality causing cancers for a woman. When we think about breast cancer and ovarian cancer, we think about hereditary risk. For breast cancers, the hereditary risk is around 5 to 10%, whereas for ovarian cancer, it comes to around 15 to 20%. But in that hereditary risk, in that 5 to 10% causes, 60 to 80% is caused by BRCA mutations. There are other genes which can cause the remaining 20-30%, which includes the PALB, the RAD51, the ATM, the CHEK, and the BRIP. But overall, what you need to understand, and in that 5 to 10% risk of breast cancers, around 60 to 80% is caused by BRCA gene mutations. BRCA1 and 2 carries have concurrent high risk for both malignancies, where the risk of second primary ovarian cancer in BRCA positive breast cancer survivor reaches as high as 20 to 40%. Even in our day-to-day ovarian pathologies, 15% of high-grade serous ovarian carcinoma are harboring BRCA mutations. When it comes to the age risk, BRCA1 has early onset with the average age group being around the 30s to 40s, along with triple negative phenotype of breast cancers. BRCA2 is slightly later onset between the age of 40 to 50s, with hormone receptive positive cancer commonly seen. As per the ICMR 2023, 8 to 10% of Indian ovarian cancers are BRCA positive, and the prevalence is higher in south and west of India, with urban centers showing as much as 20 to 15% mutation positivity. So, what is BRCA gene? Tumor suppressor gene, which are seen on chromosome 17, Q21 is BRCA1, the one which is seen on 13, Q12 is BRCA2. The basic work that BRCA does is homologous recombination repair of double strand DNA breaks. This is what the role of BRCA is. If this is damaged, the repair is damaged, it leads to genomic instability, and this in turn can lead to carcinogenesis. BRCA2 is also linked to male breast cancers and pancreatic cancers also. So this is one risk that you need to tell the male partner along with it. When it comes to molecular pathway, a little complicated. BRCA1 and 2, as we discussed, is a homologous recombination repair pathway gene which is responsible for repair of the double-stranded DNA. BRCA1 acts as a center and orchestrator, recruiting the repair complexes, whereas BRCA2 mediates loading of RAD51 onto that DNA damage, which is area which is damaged, and leads to accurate repair. BRCA1 is also associated with BARD1, PALB2, and MRN complex, whereas BRCA2 interacts with RAD51, DSS1, FANG-D, which is also a connecting factor between homologous repair combination along with Fanconi's anemia pathway. When there is a loss of BRCA mechanism that leads to genomic instability, this is what we already told about. Cells rely on error-prone repair mechanisms in general, and if there is this repair which is not happening, it leads to chromosomal aberrations, which can lead to oncogenesis. There's a signature 3 or the HRD associated mutation signature, which is seen in the sequencing of these damaged gene or the DNA when you do a study along with the BRCA testing. Tumor without germline BRCA mutation but with similar HRR deficiency can also lead to something which is called as BRCA NES, the PALB, the RAD5 CD losses, or the methylation of the BRCA promoter. PARP inhibitor sensitivity, even without BRCA mutation, can be seen. This is one of the major areas of target when it comes to treatment and further future researchers. The inheritance is autosomal dominant with incomplete penetrance. The lifetime risk of someone having a BRCA1 positive with breast cancer is 65 to 80%, and ovarian cancer is 34 to 45%. When it's BRCA2, there is a high risk of breast cancer between 45 to 70%, and ovarian cancer between 10 to 20%. As we also discussed, BRCA2 can lead to male breast cancers and male pancreatic cancers. The penetration mode is also modified by hormonal and reproductive factors. This is something which we know about the breastfeeding, the pregnancy aspect, and how the risk can increase if someone is a nulligravida or someone who's not breastfed. There are some different mutations which are observed in Jews, Icelandic, and the Dutch and Indian population. In recent ICMR 2023, BRCA1 has been seen to more commonly occur in Indian population compared to BRCA2, but the risk of PALB is rising in the BRCA-NES genes. So how do you come across deciding which patient requires a BRCA gene testing? This is the important slide that you need to put in your clinical practice. Anyone who has a breast cancer at the age of 40 or less, anyone who's triple negative breast cancer and the age is less than 60, if there is a bilateral breast cancer or if there is a family risk of male breast cancer, if there's a familial or a personal history of ovarian cancer, pancreatic cancer, and prostate cancer, or if two or more relative first degree relatives have breast and ovarian malignancy. So anyone less than 40, less than 60, or if there's a family history of breast and ovarian cancer, in such patients, you should be thinking about doing a breast cancer BRCA testing gene. So when you ask for a patient for a BRCA gene testing, there should be a pre-test counseling, because what the patient needs to know is why you're getting this test done. There should be an informed consent regarding, yes, these are the test results that can happen and the post-test implication that will be there, and how it will be affecting her life, and what surgeries or how beneficial things will be for her. There might be requirement of a series of relatives that can be tested for the same thing. You need to assure the patient psychologically that yes, these are the risks that are involved. In cases of surgeries that can be there, the patient has to be financially also there. And if it is a young patient with a BRCA positive gene, then you need to also consider her reproduction and her family life. So there are different testing technologies that are available. The NGS panel, which is there. There is an HRD spore integration, which can be there. There are some somatic gene testing that can be done from saliva or blood, whereas a germline thing that can be done from tumor tissue also. Currently, we are also focusing on liquid biopsy for BRCA1 and 2 mutation. In relapse under evaluation, plus liquid biopsy is, as per researchers, is known to provide better testing results compared to the ones that we were using in the past. The BRCA carriers have usually higher mammographic density, so the screening pattern for them also changes. MRI is usually advised at the age of 25 onwards. Usually, we begin mammogram from the age of 40, but in BRCA positive or BRCA carriers, we do a mammogram from the age of 35, 30. Ultrasound can also be advised. So sonomammogram is something which is done along with mammogram for denser breast. Now, what do we do? In risk reduction, there is a risk reduction surgery that can be done, or a risk reduction management that can be done, both in breast and ovarian pathologies when you come across someone who is BRCA positive. So prophylactic mastectomy can be done, which reduces the risk of breast cancers by 90 to 95%. You can also think about chemoprevention, which can include tamoxifen or aloxifene, but there is limited data for it. MRI and combination of a mammogram screening can be also advised. Something happened in 2013 where Angelina Jolie discovered her risk of breast and ovarian cancers, where she turned out to be BRCA1 positive. And when she underwent a prophylactic mastectomy and oophorectomy, this triggered the population, which made people aware regarding the BRCA gene testing and the prophylactic surgeries or risk reduction that can be done. And this increased the global testing by around threefolds. And this is what is also known as the Jolie effect. Similarly, when it comes to ovary, there is a risk reduction salpingo oophorectomy that also can be done. In BRCA1, this is advised between the age group of 35 to 40 years. In BRCA2, this is advised between the age of 40 to 45 years. As we all know, the fallopian tube is supposed to be the origination of the malignancy. So we are also doing a risk reduction salpingectomy in almost all the patients, even in non-carriers, to reduce the risk of any ovarian pathology. HRT considerations after RRSO, or the risk reduction salpingo oophorectomy, is better compared to if you're doing it without a salpingo oophorectomy case. When it comes to the male progeny in the family, BRCA2 increases the risk of male breast cancer, prostate cancer, and pancreatic cancer. As per the screening guidelines, a male should also do a breast self-examination from the age of 35 and should do a prostate screening from the age of 40 to understand the screening pathologies and to reduce the risk for the male progeny. Synthetic PARP inhibitors are something which are considered for the therapeutic or the medical management, where you have olaparib, niraparib, talazoparib, and rucaparib, which can be used as agents to reduce the risk or to manage post the surgeries. As per the FDA, Maintenance therapy approval is there in platinum sensitive relapses. Combination with immune checkpoint inhibitors are currently under trial for the same, but these are what we are considering at now. Beyond BRCA, you need to understand the HRD landscape. This is the evolution that has happened in BRCA. Homologous recombination deficiency. 50% of high grade serous ovarian and 20% of triple negative breast cancers show HRD deficiency even without BRCA1 or 2 mutation. So, what the change happened is we were seeing this in spite of BRCA being positive. So then we had to think about other things that can be related to this. So we found out certain other genes which we spoke about in the last few slides. There is the PALB, which is one of the most important things, which has almost a similar breast cancer risk as BRCA2. Along with that, there is RAD51 and RAD51C and D. There is moderate risk with ATM check and FANCA. What it helped us is with that when you have an HRD, it predicts the response to PARP inhibitors and platinum based chemotherapy so that we can manage the patient better in such situations also who are BRCA negative. There are certain commercial assays that one can do. Basically, there are tests and a graph which is pointed out, which are commercially available. You have the My Choice CDX or the Foundation One CDX. My Choice CDX measures loss of heterozygosity, telomeric imbalance, and large scale transitions. And when you have an HRD score of more than 2, it is considered to be positive. In Foundation 1, we have one step ahead integration of the HRD score along with tumor mutation burden that is added or fed to the data to give us the risk. HRD testing recommended for all advanced ovarian cancers and recurrent tumor negative breast cancers. The triple negative breast cancers, the PRP inhibitor can be used in HRD irrespective of the BRCA status. Usually, combination strategies, which is PARP along with VEGF inhibitors, are something that is approved to reduce the risk and the recurrence in some scenarios where you have BRCA negative, but you have a higher risk for a relapse or higher risk of other cancers. So this is the evolution that has happened, where you just think beyond BRCA and you have to manage the patient in such scenarios. In India, the challenges are we are limited to genetic testing access, where not all the places are still doing the BRCA gene testing. Forget reaching to the other PLB and the RAD mutation testing. There's also cultural family barriers where you don't want to disclose about the breast cancers and the risks which are involved. When you think about the risk reduction surgeries, you have to think about the cost implications also, which happens in. And we don't have a database where we can track hold or catch hold of the mutation family lineage where we can advise them something yet. And there is also ethical and psychological aspect, psychosocial aspect, where the patient goes through the guilt of a breast cancer. There's anxiety when the cancer is spoken about. We think about the reproductive concerns which are there, disclosure dilemmas, wherein who should know and what one needs to undergo regarding the treatment also. In the West, we have a GINA protective the facility which is there when there is no genetic discrimination which is done to anyone who discloses the data, but we still don't have such protections in India when it comes to genetic discriminations. Lastly, a small slide about fertility and pregnancy. When we think about fertility and the RRSO, the risk reduction strategies, when you're doing an RRSO in such patients, it is always advisable to do oocyte preservation before you jump into doing a salpingo oophorectomy. You can also think about pre-implantation genetic testing in such patients so that you can reduce or find out the risk in the progenies that can be happening in the future. Though there is limited evidence of pregnancy influencing carrier risk in BRCA carriers yet, but these are few things that you need to talk to the patient if the patient is in the fertility age group. In the future, we can have HRD as a biomarker for immune checkpoint therapy synergy. AI is something which is happening right, left, and center. So AI-driven HRD detection for histopathological slides can be done. CRISPR genes are currently the target in the evolution of biochemistry and biotechnology. So CRISPR-based repair trials are something which are there in the preclinical levels, which can help into managing BRCA mutations. Also, there are studies which are going on, trials which are going on for vaccines against BRCA mutated tumor and neoantigens. And lastly, liquid-based biopsy for minimal residual disease detection is something which is evolving and is the future for early detection and to reduce the spread after doing a biopsy. In summary, BRCA links breast cancer and ovarian malignancies through shared DNA repair defects. Early detection, counseling, and targeted therapy are the key, and guidelines are now emphasizing on personalized prevention and therapy so that we can target the person and think about what treatment will work for them and in the entire lineage of their family. Thank you.
Thank you so much, sir, for this wonderful presentation. We do have some question if you like to take that up. Yeah. So, sir, the first question is, how do BRCA1 and BRCA2 mutations simultaneously impact breast and ovarian cancer risk profiles?
We spoke about this in the slide. BRCA1 more commonly leads to higher risk of breast cancers and ovarian cancers. BRCA2 not very high, but then at a later stage in the age group also between 40 to 50, it can lead to risk of breast and ovarian cancers. What we need to differentiately understand is that BRCA2 can also lead to male breast cancers and prostate and pancreatic cancers in the same family lineage.
Next up, we have, sir, what mechanism explains the increased breast cancer risk in patient with polycystic ovarian syndrome?
In these are two different, like this is not connected to this, but then polycystic ovarian syndrome, there is a change in the hormonal profile for the patient. So more exposure of estrogen can happen. That too, estriol can be there. And plus, in such patients, if you have not asked the family history and if you're treating with OC pills, that also increases the risk. So in such situations where your ovary is not functioning well, there is an hormonal imbalance when it comes to E2 and E3. Plus, if there's not a proper history of the risk in the family involved, and if you're getting OC pills, that increases the risk of breast cancers in PCO patients.
So there is one last question. What are the emerging biomarkers that can predict combined breast and ovarian cancer?
So we read about BRCA currently; those are emerging. Along with that, you can be doing the PULB testing, PALB, and the RAD testing, which can be the future. There are the studies which I told you, the application that are there, which can be coming in, but they are still in the research phase because once they come in with the HRD studies, that will help us to predict the risk and to manage which patients will require risk reduction surgeries or treatment. In such patients, it will be easier. And obviously, rather than testing, just testing, you need to know the treatment. So the current treatment guidelines, which are along with the PARP and the olizumab variants, those things also will be helpful in managing a patient.
Thank you so much, sir, for answering all our questions. That's all from our audience, sir. Before concluding, any
Thank
take-home
you.
message from your end?
No, like I mentioned, for the physicians out there, you should know which are the risk factors or the red flags for your patient that you need to know. And once you identify them, then you need to ask for a BRCA testing. Those are expensive, but then always understand that the risk of or the implications of any malignancies are more expensive rather than just doing a genetic testing. And once you've done this, explain the patient the risk involved, the surgeries that can be done, and the treatment that can be provided, and be along with the patient when the patient needs that support from you. Thank you.
Thank you so much, sir, for joining us today. It's a pleasure to have you here, sir. Thank you so much.
Thank you. Thank you so much. Bye bye.